Hi guys, my name is Megan Yingling and I'm a part of the UIndy Occupational Therapy Doctorate Program, cohort of 2023. Today we are going to be sharing with you guys a little bit about what occupational therapy is as part of an advocacy project that we have for one of our classes. I just want to thank you guys for participating in this project with us and being willing to receive this presentation. So we hope you enjoy. First, a little bit about what we're going to talk about. First, we'll talk about what is OT, give you a little definition and history of occupational therapy. Then we'll talk about how our professions, psychology and OT, could work together. And then finally, we'll give you some very practical examples that you might see in psychology and how patients might also benefit from OT in those situations.
So first we're going to talk about what occupational therapy is. How did it start and how do we define it? So when you hear occupational therapy, you probably think it has something to do with getting somebody a job. Really, when we talk about occupations, we're talking about things that you do every day. You might not realize it, but those small things that you do every day give a lot of meaning to your life. So as OTs, we decide what activities are considered occupations, which are those little deeds that you do every day, by considering what roles our client holds. So on the slide there are a few examples, but there are countless roles that a person can hold in their family, their friend groups, professional teams, or even just in their free time. OT steps in when a person's condition is no longer allowing them to participate in those role-defined occupations. Occupational therapists treat their clients and their caretakers holistically. So that means we're setting goals with the clients to address all aspects of their lives and occupational performance. When they set those goals with us, that means they're working towards something that's meaningful to them, not just what we think that they should be able to do. Now I'm going to ask you to think about your occupations. What are your roles? Are you a student, a mother, a team member? For those roles, what occupations are required of you? So for a student, an occupation is attending class. For a mother, it might be, driving your children around. For someone on a team, it could just be as simple as being able to play your sport. So now imagine that something's preventing you from taking part in those activities. Who can help?
So here we have the history of occupational therapy. It kind of began in 1914 with George Barton. He was one of the founding members of occupational therapy. He utilized the arts and crafts movements of the 1860s as a means to rehabilitate individuals with a variety of disabilities. He himself was also disabled. In 1915, Eleanor Slagle, another founding member, she opened the Henry B. Favell School of Occupations at Hull House in Chicago, which was the first school to teach occupational therapy. She was also the director of the occupational therapy department at Johns Hopkins Hospital, and in 1917, they had the founding meeting for the National Society for the Promotion of Occupational Therapy. This is important because this is where our association stems from. It was later named the American Occupational Therapy Association, or as you might know it as AOTA. And then in 1918, we were involved in World War I. We sent reconstruction aids to France, and they really worked on the reconstruction aids worked on soldiers recovering from shell shock and war neurosis. They also worked with soldiers with physical disabilities and provided pain management. Other founding members include Susan Cox, Dr. William Rush Dunton Jr., who was a psychiatrist who introduced crafts into his therapy, and Thomas Kinder, who was an architect who constructed institutions for individuals with disabilities. And back to Susan Cox, she actually advocated for occupational therapy as well as taught occupational therapy at Columbia University. Susan Tracy, she's not listed on here. She's also not one of the founding members, but she was an important part of occupational therapy. She was a nurse during the arts and crafts movements, and she used crafts with her patients to rehabilitate them. She also trained other nurses in the use of occupations.
Now we are going to talk about how occupational therapy and psychology can work together and the types of settings that they may work together in. Mental health is a growing interest for occupational therapists. Some of the settings that an occupational therapist may work with a psychologist are hospitals, schools, community groups, skilled nursing facilities, child and youth mental health, adult mental health services, community mental health centers, psychosocial clubhouses, homeless and women's shelters, correctional facilities, homes, and work sites.
There are several ways in which our professions overlap. For instance, OTs use psychology principles to frame treatment interventions. OTs can help psychologists with their clients, and psychologists can refer their clients to OTs. So let's explore this topic further. One important aspect of occupational therapy is our frames of reference. A frame of reference is a practice guideline in a specific domain, and it describes the process of change within that domain. It defines the principles for moving a client from function to dysfunction, and the frames of reference help steer the way we treat our clients. We have two frames of reference within OT that come from psychology, one of which is the cognitive behavioral frame of reference. The focus for this is that thinking influences behavior, and OTs use the cognitive behavioral frame when psychological barriers prevent activity engagement for our clients. And to use this frame of reference, we treat thoughts as behaviors that can be modified. Example interventions include relaxation and visualization exercises, thought stopping, and decatastrophizing. We also have the psychodynamic frame of reference, and this frame's focus is self-identity, self-direction and motivation, self-awareness, self-management, and social identity and relationships. OTs use this frame of reference to help clients identify unconscious conflicts and fixations, as well as to gain insight into behavior, beliefs, and values. So, how do we use this frame of reference? Well, interventions with this frame of reference are facilitated through activities that can help bring unconscious material into the conscious mind, which allows for a clearer understanding of underlying conflicts, while at the same time begins the process of resolving those conflicts. And the intervention activities are selected for their symbolic potential, as well as the potential to provide an appropriate level and type of social interaction and to match the client's needs.
So on this slide, I want to talk to you guys about why we would make referrals, why OT would refer psychology, and why psychology might make a referral to OT. So generally speaking, referrals are a way for our professions to put people in touch with the necessary resources that they might need in order to achieve whatever their goals are. So for example, OTs could be assessing a client or seeing a client for a while and realize that maybe what they really need is someone who is more well-versed in psychometrics than we are. And so we could make that referral to you guys. And on the flip side, psychologists could maybe see a client and think that maybe they could benefit from different environmental modifications or adaptations in order to give them a fuller, holistic plan of care. And that's the other thing about referrals is that it can be a collaborative process between our two professions. It doesn't have to be one or the other handing them off to you guys. You guys don't have to hand them off to us. We can work together to give our clients the best care that they need in order to achieve whatever their goals are. And I think that in general, there's a lot of power to assessing our own strengths and weaknesses as clinicians and recognizing when maybe our patients would benefit from the services of another profession. So I hope that you guys enjoy the next few slides where we'll be giving you some concrete examples on how referrals between OTs and psychologists might look.
OTs can help psychologists. So first of all, OTs put an emphasis on activities of daily living or ADLs. Some examples of ADLs can include going to the bathroom, getting dressed, brushing your hair, brushing your teeth, different things like that that we all do throughout our day. Secondly, OTs can address discharge preparedness, so we can assess your client to see if they're ready to go home or if maybe they need to go to a transitional facility if they're not quite ready to go home just yet. Thirdly, we can work on calming and grounding strategies. So these are some things that you're probably already working with your clients on, but we can just make sure that they get that extra help that they need in order to work on those skills and really establish those. And finally, OTs address clients' physical well-being as well as their mental well-being. So you as psychologists are working on their mental health and really emphasizing their mental well-being, but OTs take a holistic approach to care. So we're looking at the whole of the client. So we're looking at their physical, mental, social, all different aspects of the client to make sure that they just have the best quality of living.
All right, now we're going to talk about some very practical psychology examples. So we'll start with trauma. What you might see as a psychologist would be a client having a session with you who's struggling with past trauma, reporting that they aren't able to properly take care of themselves, possibly. In that situation, you could refer to an OT, and the OT would step in by identifying those daily activities. Maybe it's making breakfast or getting dressed in the morning or bathing or showering that the client is not able to complete the way they'd like to, and we can help them make a plan or help work on how to do those things better to their satisfaction. Another common situation that you guys might see is pediatrics. I know some of you definitely want to work with kids. So one of you might be seeing a young client who's behaving badly during a session. They're not able to sit still, or they're extremely unfocused, or their caregiver is reporting this to you during their sessions. As an OT, we see behavior and we often think sensory. So we're going to identify the cause of that behavior, usually sensory in young children. So sometimes they're overstimulated or understimulated and seeking more stimulation. And we have this frame of reference that's called sensory integration that we can use to help those kids better cope with sensations and focus on the task at hand, to then send them back to you and hopefully have them behave a little bit better in those situations. Finally, the justice system. I know there's a few of you who also want to work with possibly incarcerated clients. So you might see an incarcerated client who's concerned about his, her, or their transition back into the community. And OTs also work in prison systems. We help to identify the role shift that's about to take place, and we make a plan on how to adjust. We work on things that we call instrumental activities of daily living. So those include budgeting, transportation, meal prep, as I've listed there. So just things that you and I need to know to function in the community that someone who's incarcerated may need to work on before transitioning back into the community.
Another thing you might see as psychologists is a client with OCD. So in this case, you would see a client who's consumed with obsessive thoughts or compulsive behaviors that are interfering with their participation in their daily activities, their routines, their maintenance of relationships. OCD is definitely a very all-encompassing mental illness. So as psychologists, you could refer these clients to us as OTs, and occupational therapists will be able to help clients with OCD to identify possible triggers to their thoughts or compulsive behaviors and to develop occupational-based strategies, so to find activities and occupations that they can use to help mediate these intrusive thoughts and actions. Another type of client that you might see is clients with eating disorders. So you'll see somebody struggling with their body image, with restrictive or binge eating, with difficulty in participating in their daily activities due to their body image and their struggles around food. And as we know, a lot of our daily activities revolve around food. So this is another disorder that can really affect people's daily living. So as OTs, we can help to create holistic strategies that focus on the whole person to challenge their negative thought patterns or their behaviors and negative eating patterns, to help the client increase their own volition and motivation to engage in healthy behaviors and roles. A final type of diagnosis that you might see as psychologists could be people with really any mental health disorder any anxiety, depression, mood disorder, schizophrenia, any kind of psychiatric disorder that you see in outpatient or inpatient could also benefit from occupational therapy services because we can use client-centered care to help them foster a sense of hope and self-empowerment and to help them develop increased independence in their lives and their activities and a sense of self and a sense of purpose as they go about their daily activities.
We so appreciate you guys taking the time to learn a little bit about occupational therapy by watching this presentation, and we look forward to working with all of you great psychologists in the future. If you guys have any questions at all about anything in this presentation, you can feel free to email our group at my email, yinglingm@und.edu, and we'll get back to you as soon as we can. Thanks, guys. Have a great day.